These are the learning objectives for multimodal analgesia, a look at the opioid-sparing anesthetic. Review the science and evidence supporting best practices in enhanced recovery to optimize patient outcomes. Describe commonly used analgesic drug classes and individual drugs used for opioid-sparing techniques. Review non-opioid analgesics in terms of mechanisms of action, doses, risk, and benefits. Review potential adverse effects of perioperative opioids. List the mechanism of action for psychotropic and anticonvulsant agents used as analgesic adjuncts. And finally, list alternatives to opioids for perioperative pain control based on each agent's pharmacological and pathophysiological effects. General anesthesia is a drug-induced reversible state consisting of unconsciousness, amnesia, anti-nociception, and immobility, with maintenance of physiologic stability. Balanced general anesthesia, the most common management strategy used in anesthesia care, entails administering a combination of different agents to create the anesthetic state. Anesthetists developed this approach to avoid sole reliance on ether for maintenance of general anesthesia. There is evidence that balanced general anesthesia uses less of each drug than if the drug were administered alone. This approach is believed to increase the likelihood of a drug's desired effects and reduce the likelihood of its side effects. Current practice of balanced general anesthesia relies on a hypnotic such as propofol for induction and an inhaled anesthetic agent, or on a hypnotic infusion to maintain unconsciousness. Although Versed is often administered before induction to treat anxiety, amnesia is managed implicitly by rendering the patient unconscious. And while muscle relaxants are administered to produce immobility, administration of propofol and of inhaled anesthetics also contribute to muscle relaxation. To date, balanced general anesthesia has relied almost exclusively on opioids administered as intermittent boluses or as a continuous infusion to manage nociception intraoperatively and pain postoperatively. Nociception versus pain. Nociception is a propagation through the sensory system of potentially noxious and harmful stimuli, whereas pain is the conscious perception of nociceptive information. For example, if a patient is unconscious after receiving only propofol and has an increase in heart rate and blood pressure in response to surgical incision, this is an example of nociception. If a surgeon makes an incision to create a dialysis fistula after an inadequate administration of local anesthesia for a field block, and the patient says, "ow," then this is pain. The heart rate and blood pressure most certainly would go up as a physiologic response. Someone monitoring the vital signs but unable to hear the patient would appreciate the patient's nociceptive response. Nociception induced by surgery due to tearing of tissue and inflammation is the primary reason for placing a patient in a state of general anesthesia. If not controlled, nociceptive perturbations are also the primary source of hemodynamic and stress responses intraoperatively and of chronic pain syndromes postoperatively. While opioids are the most effective anti-nociceptive agents, they have undesirable side effects, including respiratory depression, nausea, vomiting, urinary retention, constipation, ileus, and pruritus. Over-reliance on opioids has certainly contributed to the opioid epidemic in the United States. Propofol and the inhaled anesthetic agents also contribute to anti-nociception by maintaining unconsciousness and thereby altering perception of nociceptive stimuli. The nociceptive system of the body consists of the nociceptors, the ascending nociceptive pathways, and the descending nociceptive pathways. Nociceptors are unspecialized, bare nerve cell endings located in the peripheral tissues and in the viscera that initiate nociception of pain. The cell bodies arise in the dorsal horn of the spinal cord and send one axonal process to the periphery and the other to the spinal cord or brainstem. The ascending pathways transmit nociceptive stimuli from the periphery to the spinal cord, to the brainstem, the amygdala, the thalamus, and on to the primary and secondary sensory cortices. The descending nociceptive pathways begin in the sensory cortex and project to the hypothalamus and amygdala. The projections from the hypothalamus and amygdala synapse in the periaqueductal gray in the midbrain and the nucleus of the trax solitarius and the rostral ventral medulla in the medulla. The periaqueductal gray projects to the spinal cord primarily through the rostra ventral medulla. The descending pathways are activated immediately by the ascending nociceptive pathways and modulate nociceptive information transmission. Because there are multiple different neurotransmitters and neural relays in the ascending and descending pathways, there are multiple targets at which anti-nociceptive agents can act to disrupt nociceptive information processing. Targeting simultaneously multiple targets in the nociceptive system is the key concept underlying the design of a multimodal strategy for nociceptive control and hence multimodal general anesthesia. Spurred by concerns about opioid overuse and their undesirable side effects, strategies for balanced general anesthesia are now using multiple agents in addition to or in lieu of opioids to manage the nociceptive component of the anesthetic state. Under this approach, called multimodal general anesthesia, the additional drugs may include agents with specific central nervous system targets, such as dexmedetomidine, as well as one whose targets are less specified, such as lidocaine. It is postulated that the use of more agents at smaller doses further maximizes the desired effects while minimizing the side effects. And while the multimodal approach appears to maximize the benefit to side effect ratio, no rational strategy for choosing the drug combinations has been proposed. In the past 2 decades, opioids have been prescribed increasingly for the treatment of various chronic pain conditions and during the perioperative period. Perioperative opioid administration is associated with well-known adverse effects and recently to long-term use and poor surgical outcomes. Opioid-free anesthesia is a safe option for anesthesia administration that maximizes a patient's respiratory ability and aggressively treats their pain, while eliminating the unwanted side effects of opioids. The multimodal approach to analgesia and anesthesia is recommended by the American Association of Nurse Anesthetists. This approach treats pain with a combination of opioids and non-opioids with 2 or more mechanisms of action to better manage postoperative pain and minimize opioids' harmful effects. After surgery, changes in the body's nervous system sensitize and magnify the pain the patient feels. By understanding this, we can treat postoperative pain like a disease and give medications that protect the patient from this phenomenon and increase comfort, healing, and function after surgery. Reasons that anesthesia providers choose opioid-free anesthesia include providing superior postoperative pain control by protecting the patient from surgical and opioid-induced hyperalgesia, minimizing respiratory depression in patients that have impaired respiratory function, such as COPD, sleep apnea, or obesity, treating patients who have chronic pain conditions, are on chronic opioid therapy, are heroin or opioid addicts, or are in recovery and treatment for opioid addiction, and minimizing postoperative cognitive dysfunction. Deaths from opioid overdose continue to rise in the United States. The number of prescriptions for opioids quadrupled between 1999 and 2015, and access to illegal synthetic opioids such as fentanyl has also. The problem has become so severe on U.S. college campuses that some schools have begun stocking naloxone to reverse opioid-induced respiratory depression in emergency situations. In 2017, Brumman and others reported data on 36,177 surgical patients in whom new persistent opioid use, defined as an opioid prescription fulfillment 90 to 180 days after the surgical procedure, was identified after both major and minor surgical procedures, and the rate of new persistent opioid abuse of approximately 6% was similar between the 2 groups. In 2016, the CDC released guidelines for prescribing opioids to treat chronic pain. However, focus on opioid prescribing for perioperative pain has been lacking, leading Berkmeyer to conclude, given the declining rates of morbidity and mortality following common elective procedures, new persistent opioid use represents an important, common, and unrecognized complication of perioperative care. Using opioids alone to treat postoperative pain may adversely affect the patient's postoperative recovery. Enhanced recovery after surgery, or ERAS, and multimodal analgesia are established care models that minimize perioperative opioid consumption and promote positive outcomes after surgery. Opioid-free anesthesia is an emerging technique that may achieve similar goals. Enhanced recovery pathways are multidisciplinary pathways aimed at reducing the stress of surgery and thereby accelerating functional recovery. A key principle of ERPs is that anesthesia, surgery, and the nursing team works together to decrease perioperative opioid use by implementing a multifaceted analgesia technique through all phases of perioperative care. The goal is to deliver optimal analgesia. Optimal analgesia can be defined as a technique that optimizes patient comfort and facilitates recovery of physical function while minimizing the adverse effects of analgesics. To facilitate this goal, preoperative patient education is key. As pain is a complex and subjective biopsychosocial experience, optimal analgesia cannot be achieved without management of patient expectations and education regarding realistic goals of pain treatment. It is critical for the patients to understand that pain-free is not the primary goal of optimal analgesia. The exact components of an enhanced recovery pathway will vary from institution to institution based on local factors, as well as the surgical and patient population. Importantly, there are many ways to achieve optimal analgesia that are efficacious. Each pathway should include a well-structured and planned multimodal approach from the preoperative period into the post-discharge recovery phase. It is also recommended that each pathway should have a Plan B to allow for individual patient variation and a rescue analgesia pathway to troubleshoot breakthrough pain while continuing enhanced recovery principles and minimizing the negative effects of intravenous opioids. High compliance with a variety of standardized non-opioid ERP bundles is strongly associated with a significant decrease in primary inpatient opioid consumption and improved outcomes in a variety of surgical procedures. Although multimodal analgesia routinely continues after hospital discharge, at present, most current pathways in the U.S. do not include any guidelines on discharge opioid prescribing. With recent data showing that ERP implementation has not reduced the amount of opioid prescribed at discharge, this appears to be a missed opportunity and should be addressed as ERPs evolve. Administering non-opioids may result in an opioid-sparing effect. In other words, the patient may require less opioid medication for effective pain control. Consequently, this will reduce his or her risk of opioid side effects and dependence. Combined opioids with non-opioids creates a synergy that magnifies the analgesic effect of each. This improved analgesic coverage and mitigation of side effects leads to positive patient outcomes. These include better pain management, shorter hospital stays, and increased patient satisfaction. Prior to the widespread adoption of opioids into anesthesia practice in the late 1960s, anesthesia was obtained through the use of inhaled anesthetics and/or high doses of pentothal. Unfortunately, this brought with it the complication of hemodynamic instability and the suppression of hemodynamics requiring additional support. With the introduction of opioids came the concept of balanced anesthesia, which was widely embraced for its lack of effect on the cardiovascular system. The introduction of opioids was important because hypnotics at the time were strong cardiovascular depressants. Many patients had undiagnosed or untreated cardiovascular coronary diseases, as understanding was limited at that time. So by giving high doses of opioids, it allowed the anesthesia provider to reduce the doses of hypnotics and muscle relaxants. Today, hypnotics and neuromuscular blocking agents are much more stable and can be titrated to achieve a sufficient depth of hypnosis and muscle relaxation with minimal risk. And ideally, almost all patients today have been diagnosed and treated for their cardiovascular problems prior to presenting for elective surgery. Now there are drugs which can act to stabilize the sympathetic nervous system, including alpha-2 agonists such as clonidine and dexmedetomidine, local anesthetics given intravenously like lidocaine, magnesium, and numerous other agents. Given alone, almost all of them will reduce the intraoperative opioid use when given in sufficiently high doses, which may result in prolonged sedation. If, however, these are given together in a multimodal approach, it may be possible to avoid all intraoperative opioids and avoid excess sedation. The advantage of such a multimodal approach is that postoperative opioids given as analgesics are then also dramatically reduced. From an anesthetic perspective, one can perform an opioid-free anesthetic while still providing satisfactory pain control. We are left to wonder, why is not this approach adopted by the anesthesia community at large? Opioid-free anesthesia is something one has to learn. OFA is also a paradigm shift in thinking for many practitioners. At many institutions, the OFA concept can be met with a healthy degree of skepticism. However, it is now becoming established for many minor to moderate pain procedures and has significantly reduced, if not altogether eliminated, the requirements for opioids to control pain. The goal is not to leave patients in pain, but for many patients to complete their surgical journey with satisfactory pain relief without the need for opioids. Medications such as acetaminophen, gabapentin, pregabalin, ketamine, magnesium, dexamethasone, NSAIDs, and lidocaine are among those that have been studied as components of the multimodal approach. In order to look at where we are going, we have to look at where we've been. We will discuss the medications used in the multimodal approach and conclude with a table of recommended doses and infusion rates. Opioids, the primary class of drugs, uses anti-nociceptive agents, target multiple classes of opioid receptors in the periaqueductal gray, the spinal cord, the amygdala, the rostral ventral medulla, and the cortex. Binding to opioid receptors disrupts information transmission in the nociceptive circuits by decreasing conductance of voltage-gated calcium channels and opening of inward rectifying potassium channels. Activation of the opioid receptors has two principal effects on nociceptive information transmission: blocking afferent nociceptive inputs into the spinal cord and enhancing descending inhibition of nociceptive inputs beginning at the level of the periaqueductal gray. These two effects of opioids decrease nociceptive information processing. In contrast, actions of opioids in the amygdala decreases nociceptive perception and the emotional effect of nociceptive and pain stimulation. These multi-site anti-nociceptive effects are also one of the mechanisms through which opioids decrease arousal. Opioids also decrease arousal through their inhibitory actions on brainstem cholinergic circuits at the level of the lateral dorsal tegmental nucleus, the peduculopontine tegmental nucleus, the median pontine reticular formation, and the thalamus. Opioids enhance cholinergic input into the sinoatrial node, induce bradycardia, and thereby mitigate sympathetic responses associated with nociception. Opioids provide hemodynamic stability through suppressing the sympathetic system, which is why they are preferred at induction. In addition, opioids are among the strongest analgesics, and analgesia has become an essential part of balanced anesthesia. The introduction of intravenous anesthetic agents is of historical interest. John Lundy of Mayo Clinic published an initial report in Minnesota Medicine in 1926. A full report followed in the Journal of the American Medical Association in 1931. At that time, intravenous access was not standard practice. Lundy introduced the term balanced anesthesia and suggested that using lower doses of more than one anesthetic agent improved outcomes. This thought process led to the adoption of the so-called nitrous oxide narcotic anesthetic. Nitrous oxide combined with oxygen in a 60-40 ratio, supplemented with intermittent intravenous doses of morphine sulfate. In 1993, Caylett and Dahl introduced the term multimodal analgesia for management of postoperative pain, along with the term balanced analgesia, and Wolf and Chong introduced the term preemptive analgesia. Thus, the confluence of volatile anesthetic agents, intravenous anesthetic agents, and regional and neuraxial anesthetic techniques gained favor among clinicians for improved pain management. Thus, the confluence of volatile anesthetic agents, intravenous anesthetic agents, and regional and neuraxial anesthetic techniques gained favor among clinicians for improved pain management. Who first proposed continuous infusion of lidocaine for anesthesia and analgesia is not clear, but both surgical and medical literature report the use of this technique, resulting in a more rapid return of bowel function, improved postoperative analgesia, and shorter length of stay for surgical patients compared to a control group of surgical patients. Continuous infusions of anesthetic and analgesic agents became more popular as drugs with a shorter half-life than other intravenous anesthetic agents and a predictable volume of distribution were developed. Let's move on to our more common intravenous agents. In addition to using non-opioid analgesics as adjuncts to opioids, the surgeon or anesthesia provider may choose to use a local anesthetic agent, such as wound infiltration or peripheral nerve block, to minimize the need for opioids. Lidocaine has analgesic, anti-inflammatory, and anti-hyperalgesic properties. Because lidocaine infusions have been used to treat cardiac arrhythmias, its plasma levels for therapeutic effect and specific organ toxicity are well established. Lidocaine has two active metabolites. Monoethylglycine xylidide that is further metabolized to xylidine. MEGX is 80% as active as lidocaine, and xylidine is 10% as active as lidocaine. Lidocaine is metabolized in the liver and excreted by the kidneys. Sub-anesthetic doses of lidocaine, the stated goal for opioid sparing, block ectopic nerve discharge but not conduction. Because of its pharmacokinetic profile, the drug should be used with caution in the elderly, in patients with known hepatic or renal dysfunction or heart failure, or in patients taking drugs that interfere with the cytochrome P450 enzyme. IV lidocaine infusions have been shown to reduce opioid consumption, decrease postoperative pain, reduce the hospital length of stay, and have earlier return of bowel function in open abdominal procedures. In some surgeries, this begs the question whether or not epidural infusions of local anesthetics are necessary. A study by Terwacki and others reported that IV lidocaine infusion in major abdominal surgery was inferior to epidural analgesia with respect to opioid consumption. However, lidocaine was associated with improvements in several important aspects of recovery. The table to the right are dose-dependent effects of lidocaine based on plasma levels. The reported benefits of perioperative lidocaine infusion include reductions in pain, nausea, ileus duration, opioid requirement, and the length of hospital stay. These effects are observed with infusion rates of intravenous lidocaine that mimics plasma lidocaine concentrations obtained during epidural administration. No established mechanistic explanation exists for these effects, although a reduction in opioid requirements might be a factor common to several of them. In the majority of trials, the clinical effect of lidocaine exceeded the duration of the infusion by more than 8.5 hours, which is 5.5 times the half-life of the compound. The temporal extent of this effect is an index used as a measure of preventive analgesia. The challenge then is to explain how these benefits can occur at the relatively low blood concentrations attained during infusion and how they can persist for many hours or even days after the termination of the infusion. It appears that mechanisms are set into motion by lidocaine that persist long after the drug is metabolized to non-biologically active concentrations. This mechanism is likely not primarily a sodium channel blockade, as typical perioperative blood levels would only block a very small proportion of neuronal sodium channels, and at least one target likely to be of importance, the polymorphonuclear granulocyte, does not express sodium channels. Instead, interference with other molecular targets, in particular those involved in inflammatory signaling, seem likely. However, neuronal effects may play a role as well. In addition to improving analgesia, perioperative lidocaine infusion shortens the duration of the postoperative ileus by an average of 8% and decreases the incidence of postoperative nausea and vomiting by 10 to 20%. It seems likely that these benefits are due in part to opioid-sparing effects. However, studies reported reductions in opioid consumption but no effect on PONV suggest that there is not a simple causal relationship. Perioperative lidocaine infusion reduces the length of hospital stay by an average of 8 hours and up to 24 hours. An infusion may also be a useful analgesic adjunct in enhanced recovery protocols. Lidocaine infusions were used in an enhanced recovery protocol for patients undergoing open and laparoscopic colorectal surgeries, which showed benefits in pain scores, opioid consumption, length of hospital stay, and other outcomes. Perioperative lidocaine infusion may also be considered for enhanced recovery procedures for other types of surgery where the available evidence suggests that there may be a possible benefit and minimal risk of neurologic and cardiac side effects. Although the accumulation of lidocaine is a concern with continuous infusion, at doses used in the studies cited here, plasma concentrations remain well below the toxic level, even after 24 hours. Toxicity from perioperative lidocaine infusions is exceedingly rare but may present with symptoms of tinnitus, perioral numbness, and cardiac dysrhythmias. Monitoring the plasma lidocaine levels may be considered in patients at increased risk for lidocaine toxicity, such as those with abnormal liver or kidney function, or those who cannot be queried about symptoms of lidocaine toxicity. Let's take a break from IV medications and talk about regional anesthesia. The use of regional anesthesia is essentially a universally utilized component of any perioperative multimodal analgesia or EROS pathway. Both neuraxial and peripheral nerve blocks can be used concurrently with an opioid-free anesthetic. A patient may be able to remain opioid-free from the first few hours after surgery and possibly for days depending on the type of block and surgery performed. Epidural catheters play an important role in opioid reduction in EROS pathways, as well as enhancing early recovery. One of the benefits cited for epidural use in open abdominal surgery EROS pathways relates to the role epidural catheters play in reducing opioid-related adverse events. Specifically, adequate pain control through opioid-sparing analgesic techniques aids in the reduction of postoperative nausea and vomiting, ileus, somnolence, hyperalgesia, and postoperative delirium. More recently, some of the focus on regional anesthesia and analgesia for a variety of abdominal surgical procedures, both as part of EROS pathways and independently, has shifted to truncal fascial plane blocks, including TAP blocks, rectus sheath, and quadratus lumborum blocks. While many of these fascial plane blocks have been performed as single injection with ropivacaine and bupivacaine, a desire to prolong the time to rescue with opioid analgesia or to completely avoid opioids altogether has led to the use of both continuous indwelling regional catheters and liposomal bupivacaine. Recent studies of TAP blocks with liposomal bupivacaine for robotic-assisted hysterectomies and colorectal surgery showed lower pain scores and decreased postoperative opioid requirements in the first 72 and 36 hours, respectively. Additionally, regional anesthetic techniques are quite useful for opioid-tolerant patients who have poorly controlled postoperative pain. In fact, it has been suggested that regional anesthesia and analgesia procedures be offered to opioid-tolerant patients whenever feasible. With the variety of regional techniques available and the flexibility of these techniques regarding different surgical procedures, regional anesthesia and analgesia uniquely positions the anesthetist to have a significant impact in the reduction of opioids in the perioperative period. Now on to alpha-2 agonists. The two common alpha-2 agonists used in clinical practice today are clonidine and dexmedetomidine. The primary mechanism of antinociception is the direct stimulation of the alpha-2 adrenoreceptors in the CNS and spinal cord. Dexmedetomidine, the alpha-2 adrenergic receptor agonist, like clonidine, exerts its antinociceptive effects in two primary locations. At the cellular level, alpha-2 agonists inhibit cyclic adenine monophosphate, which reduces potassium efflux and calcium influx, causing a hyperpolarized state of the adrenergic neurons. When hyperpolarization occurs, there is a reduced norepinephrine release, which is postulated to be the mechanism of hypnosis and sedation. Direct stimulation of alpha-2 receptors also inhibits nociceptive neuronal firing, thereby reducing the release of substance P, a key excitatory neuropeptide responsible for painful responses. It enhances descending inhibition of nociceptive transmission by activating inhibitory interneurons that synapse onto projection neurons in the dorsal horn of the spinal cord. Dexmedetomidine also exerts a key antinociceptive effect by decreasing arousal. In this regard, dexmedetomidine acts presynaptically to decrease the release of norepinephrine. Decreased norepinephrine release in the preoptic area of the hypothalamus disinhibits GABAergic and GABAergic inhibitory projections to the major arousal nuclei in the midbrain and pons. The actions of dexmedetomidine at these principal targets leads to a substantial decrease in arousal due to decreased noradrenergic excitatory inputs to the preoptic area of the hypothalamus, the thalamus, the basal forebrain, and the cortex. Under dexmedetomidine, the electroencephalogram shows spindle oscillations and slow delta oscillations at low to moderate doses and only delta oscillations at high doses. Dexmedetomidine has hypnotic, sedative, and analgesic effects and is estimated to be 7 to 10 times more potent than clonidine. Compared to clonidine, dexmedetomidine is a full rather than a partial agonist and highly selective and specific for the alpha receptor. Precedex has a much higher affinity, approximately 8 to 1, than clonidine at the alpha-2 receptor site. Both agents may significantly reduce opioid consumption, postoperative nausea and vomiting, anxiety, postoperative shivering, and stress responses intraoperatively. The most common side effects of alpha-2 agonists are hypotension and bradycardia. Perioperative administration of the alpha-2 agonists, clonidine and dexmedetomidine, has been shown to reduce postoperative opioid consumption by 4 to 15 milligrams of morphine equivalents respectively, as well as reduce the pain intensity and nausea in patients. The drug is protein-bound and, like lidocaine, is metabolized in the liver with subsequent renal excretion. Usually administered by continuous infusion, dexmedetomidine is used to provide hypnosis and sedation in addition to its analgesic properties. Pre-treatment with dexmedetomidine attenuates the adrenergic response to tracheal intubation and decreases plasma catecholamine concentrations during anesthesia. Infusing dexmedetomidine results in a decrease in MAC for volatile anesthetic agents and has an opioid-sparing effect. The analgesic effect is dose-dependent with little or no depression of ventilation. Loading doses of dexmedetomidine to rapidly reach the desired therapeutic effect may cause hypotension and bradycardia. Dexmedetomidine attenuates the cardiostimulatory effects and post-anesthetic delirium induced by ketamine. Ketamine is a phencyclidine that was originally demonstrated to have a specific effect on NMDA receptors in the brain, a mechanism of action quite different than other anesthetic agents. The principal anti-nociceptive effects of ketamine are due to its targeting of NMDA glutamate receptors located on the peripheral afferent nociceptive neurons that synapse in the dorsal horn of the spinal cord. The mechanism of action of ketamine is quite different than any other anesthetic agent. Glutamate is the primary excitatory neurotransmitter in the nervous system. Blocking nociceptive inputs at this juncture impedes the entrance of these signals into the spinal cord. The action of ketamine at NMDA receptors in the cortex and other parts of the arousal system contribute both to its anti-nociceptive effects and to its capacity to decrease arousal. NMDA antagonists are also commonly used medications in a multimodal pain regimen. The drug has since been demonstrated to have a more distributive effect in other parts of the brain, like the thalamus and limbic systems, and analgesic effects that are mediated at the level of the spinal cord. Ketamine is an amnestic and provides intense analgesia. The analgesia is profound even at sub-anesthetic doses. At higher doses, ketamine can be a complete anesthetic. At low doses, ketamine binds preferentially to NMDA receptors on GABAergic inhibitory interneurons, leading to a general disinhibition of pyramidal neurons and diffuse excitatory cortical activity. This activity is marked by gamma oscillations in the EEG and an altered state of arousal that commonly includes hallucination. At higher doses, ketamine also blocks NMDA receptors on excitatory pyramidal neurons. Pyramidal neurons with NMDA receptors can be found in many locations throughout the brain and CNS. However, key targets for altering arousal are the glutamatergic projections from the parabrachial nucleus and from the medial pontine reticular formation in the brainstem to the thalamus and to the basal forebrain. These glutamatergic projections are very potent excitatory arousal pathways. At higher ketamine doses, inactivation of these arousal pathways leads most likely to profound unconsciousness, marked by EEG patterns which show profound, slow delta oscillations alternating with gamma oscillations. Ketamine may produce anti-hyperalgesic effects through the reduction of NMDA receptor activity. Sub-anesthetic doses of ketamine are thought to possibly reverse tolerance to opioids. The drug exhibits extreme lipid solubility, rapid transfer across the blood-brain barrier, and a large volume of distribution. The half-life is 2 to 3 hours, but even so, the drug has been successfully employed by continuous infusion. Ketamine, an NMDA receptor antagonist, has been shown to decrease acute post-surgical pain and analgesic consumption. It is very effective in helping to decrease tolerance to post-operative opiate use, as well as being an effective analgesic. Loftus and others found that ketamine reduced opioid consumption in the postoperative period 0 to 48 hours. Moreover, these investigators found that opioid-dependent patients treated with ketamine had reduced pain up to 6 weeks after surgery compared to controls. More recently, Nielsen and others reported that ketamine administered intraoperatively during spinal fusion surgery significantly decreased opioid use during the first 24 hours postoperatively. In addition, these chronic pain patients with chronic opioid use receiving intraoperative ketamine had significantly less sedation and significantly improved pain scores at 6 months. This highlights ketamine's long-reaching effects at improving pain while achieving reduced use of opioids. The side effects of ketamine include increased sympathetic activity, elevated intracranial pressure, increased salivation, nystagmus, and hallucinations. Therefore, caution is advised when using ketamine in patients with coronary artery disease, intracranial pathology, and psychiatric comorbidities. Although not in our usual formulary, here is an interesting note. A 2015 meta-analysis by King and others concluded that low-affinity, non-competitive NMDA receptor antagonist dextromethorphan, a common ingredient in cough syrup, significantly decreased postoperative opioid consumption 24 to 48 hours after surgery. This review of 14 trials and 848 patients found that preoperative dextromethorphan reduced morphine consumption by 10.5 milligrams postoperatively. It also decreased pain scores up to 24 hours postoperatively. Acetaminophen has a different mechanism of action than other analgesic drugs, but also has demonstrated analgesic and opioid-sparing properties. In adults, the appropriate dose for preemptive analgesia is 1,000 milligrams or 1 gram administered intravenously for approximately 20 minutes. The analgesic onset is rapid, within 5 minutes, but the peak concentration in plasma occurs at approximately 1 hour. The duration of effect is 4 to 6 hours, and the half-life is 2 to 2.5 hours. Acetaminophen undergoes metabolism in the liver by conjugation with glucouronic and sulfuric acids. These conjugates are excreted in the urine. Surgeons have embraced the use of intravenous acetaminophen, starting with a preoperative dose and repeating doses at 6-hour intervals. Acetaminophen has shown in systemic reviews and clinical trials to reduce postoperative opioid use by as much as 30%. Although most trials concentrate on IV Tylenol, a 2015 systematic review concluded that there is little evidence for using IV acetaminophen over oral acetaminophen in patients that are able to take medications by mouth perioperatively, which is useful when considering the overall medication cost. There is conflicting evidence on whether or not the reduced opioid doses reduce opioid-related side effects or opioid-related adverse events in studies with concurrent opioid use. A recent study using a nationwide database reported that in spine surgery patients, IV acetaminophen did not reduce inpatient use of opioids or opioid-related adverse events. The effectiveness of acetaminophen may be related to procedure and patient specifics. Additional trials are needed to make a definite conclusion about the ability of acetaminophen to reduce opioid-related adverse events. Dexamethasone, long used for inflammation and nausea-vomiting prophylaxis, is now gaining popularity as an adjunct in perioperative pain management. In 2011, D'Oliveira and others published a study that showed doses of 0.11 to 0.2 milligrams per kilogram of Decadron were optimal for postoperative pain reduction and decreasing opioid consumption postoperatively. This study was particularly important because before this, less than 0.1 milligrams per kilogram of dexamethasone was commonly given perioperatively for nausea vomiting prophylaxis. Additional studies continue to show the postoperative pain benefits of dexamethasone. A 2017 meta-analysis by Ming and others found that dexamethasone significantly reduced opioid consumption for the entire 48 hours after total joint arthroplasty, as well as resulted in reduced pain scores. Magnesium, the fourth most common cation in the body, plays a critical role in numerous physiological processes. In obstetrical anesthesia care, magnesium is used as an antihypertensive and a muscle relaxant to treat preeclampsia. Several of these therapeutic effects are mediated through its blockade of calcium channels. In addition, magnesium blocks NMDA receptors. Because of its inhibitory effects at glutamatergic synapses, a magnesium infusion can be used as an adjunct to reduce the dose of antinociceptive agents being administered as part of a multimodal general anesthesia regimen. Magnesium also potentiates the effects of the hypnotics on arousal. The antinociceptive and hypnotic targets of magnesium are most likely the same as ketamine. However, because magnesium is a widely prevalent ion, it most certainly contributes to these states as well through its wide range of nonspecific targets. Magnesium's profound effects on blood pressure and muscle relaxation must be taken into account when this agent is administered as part of a multimodal general anesthesia regimen. Similarly, it is important to be cognizant that high doses of magnesium can lead to decreased AV conduction, heart block, and possibly cardiac arrest. In 2013, a systematic review concluded that magnesium significantly decreased early 3 hours to postoperative and late 24-hour postoperative pain. It also significantly reduced nausea and vomiting. Patients that received magnesium infusions intraoperatively and postoperatively had a greater reduction of pain score and greater reduction of morphine use than both control groups. Morphine use decreased on average more than 10 milligrams in the immediate postoperative period, although the total magnesium dose did not affect total postoperative opioid consumption. This may be due to the fact that magnesium was given intraoperatively and did not continue into the postoperative period. Despite the large decrease in postoperative opioid, magnesium did not decrease systemic adverse effects of morphine, such as nausea and vomiting. Ketorolac is a non-salicylate analgesic agent and non-steroidal anti-inflammatory drug that has desirable characteristics in managing postoperative pain. Ketorolac's mean plasma concentrations, volume of distribution, and excretion are identical in healthy adults whether the dose is given by intramuscular, intravenous, or oral route. The pharmacokinetic profile of ketorolac in children is the same as in adults, and the volume of distribution and plasma clearance are identical. The COX-1 and COX-2 mechanisms of action may play a role in inhibition of prostaglandin synthesis, resulting in anticoagulation at higher doses. For adult postoperative patients, a 15 to 30 milligram intravenous dose of Toradol, repeated once, has been shown to be safe and effective. And for pediatric patients, ketorolac in a dose of 0.5 milligrams per kilogram with a maximum dose of 30 milligrams is similarly safe and effective. Ibuprofen, another NSAID with established analgesic and antipyretic properties, is approved by the U.S. Food and Drug Administration for intravenous administration. Doses of 400 milligrams and 800 milligrams have been shown to have an analgesic and opioid-sparing effect in postoperative patients. Smith and Voss have shown that shortening the recommended 30-minute infusion time is both safe and effective. NSAIDs are a very potent pain reliever and are often overlooked as an immediate perioperative medication due to concerns of side effects. When used in scheduled cases and in the correct patient population, they can be a powerful adjunct to any pain regimen. In a 2017 review on multimodal anesthesia, Wick and others highlighted the findings that 600 milligrams of ibuprofen is as efficacious as 15 milligrams of oxycodone. A long-held belief has been that NSAIDs, particularly ketorolac, increase the risk of surgical bleeding. Gobble and others reported findings that Toradol was not shown to increase incisional or GI bleeding in patients under 75 years old. Recent meta-analysis in pediatric neurosurgery patients and plastic surgery patients both found no increased risk of postoperative bleeding. A 2005 meta-analysis reported that NSAIDs in conjunction with opioid treatment significantly decreased pain scores at 24 hours. It also reported that it decreased morphine consumption at 24 hours by 50% with the COX-2 inhibitor Vioxx and by 40% with other NSAIDs. The addition of NSAIDs or COX-2 inhibitors to an opioid pain regimen also decreased the incidence of nausea and vomiting and sedation in both small and large surgeries. Although morphine consumption was significantly reduced, there was no reduction in opioid adverse events. However, these trials reviewed within the meta-analysis were focused on efficacy of pain control. More focused studies are needed to show how a multimodal perioperative pain regimen can reduce opioid-related adverse events. Gabapentin and pregabalin, or Lyrica, are anticonvulsant agents commonly used as perioperative analgesics. Both agents bind to voltage-gated calcium channels and promote anti-nociceptive actions by inhibiting the release of excitatory neurotransmitters. These medications were initially used for the treatment of chronic neuropathic pain, but they also may work to prevent and reduce acute pain and opioid consumption. Recent evidence also suggests that they may reduce chronic post-surgical pain, although more clinical trials are needed. Common side effects of gabapentin include increased sedation, peripheral extremity swelling, and weight gain. Gabapentin and Lyrica are also commonly used in multimodal analgesia and have shown to reduce opioid consumption in the perioperative period. Randomized, placebo-controlled, and double-blinded studies have shown that 1,200 milligrams of perioperative gabapentin reduces postoperative morphine equivalents in various types of major procedures. A meta-analysis in 2007 showed that preoperative gabapentin doses ranging from 300 to 1,200 milligrams decrease opioid use by 30 milligrams of morphine in the first 24 hours post-procedure. Lyrica has been shown in a meta-analysis to have similar effects on postoperative opioid reduction, as well as reducing opioid-related side effects postoperatively. This table illustrates common non-opioid pharmacologic agent classes, the drugs, their doses, and considerations for the medications that we have discussed. In conclusion, the opioid epidemic in the United States is a complex issue with biochemical, sociologic, and behavioral factors. The availability of synthetic opioids and the increase in illegal distribution must be addressed. Prescribing habits must be analyzed and altered to balance the obligation to adequately treat pain without subjecting patients to the possibility of addiction because of overprescribing. We know that the incidence of new persistent opioid use following surgery and medical procedures is contributing to the addiction. We know that the incidence of new persistent opioid use following surgery and medical procedures is contributing to addiction. As an alternative to opioid anesthetic regimens, we must present a multimodal approach to anesthetic care that works through the interactions of sub-anesthetic doses of IV agents and a balanced approach to pain control. The available evidence suggests that avoiding opioids during anesthesia is feasible without hemodynamic instability. Further studies are needed that look at long-term outcomes such as total postoperative opioid use, the duration of this use, the return to function, as well as the incidence of chronic pain. In the current setting of the opioid crisis, we should lead the charge to change our clinical practice to minimize or eliminate the use of perioperative opioids, which can potentially have far-reaching effects than simply length of stay or reduced nausea. The new approach in anesthesia can provide hypnosis with amnesia and muscle relaxation at the moment the anesthetist or surgeon requires it, while also maintaining sufficient tissue perfusion and sympathetic stability to protect organs. We as anesthesia providers are leading experts in pain medicine, and through evidence-based implementation such as EROS and multimodal anesthesia, the specialty is helping to address the opioid crisis by reducing the amount of opioid use in the perioperative period while still maintaining adequate acute pain control.